All right. So, hi, I'm Mike. This is Zane Sam Kanishka, and we're SleepDX. So, the problem that we're trying to address is undiagnosed COPD. So, COPD is the third leading cause of death in the United States, and despite this, about 50% of people that suffer from symptoms are undiagnosed. And that amounts to about 12 million Americans per year. And this costs the US health system $75 billion annually. But we believe that this number can be reduced by 10x if we were to diagnose people early. We also believe that the number of exacerbations and fatalities can be reduced by 10x as well through early diagnosis. So the opportunity we saw is that 3.5 million sleep studies are conducted each year. And when you go in for a sleep study, they take 26 channels of data on you for 8 or so hours. And this data is only used to diagnose sleep-related conditions, but it could also be used to diagnose non-sleep-related conditions as well, such as COPD. So the relevant data to diagnose COPD is present in the sleep study data, and it's present there before major symptoms for COPD manifest themselves. So if we could provide a probabilistic diagnosis for COPD, we could convince a patient to go get a spirometry test, which is the test they currently use now to diagnose COPD, a lot earlier. And this earlier diagnosis can result in savings of $3,700 per year on average, in some cases significantly more. So what we ended up doing was we created a data analysis platform that provides a clinician with a probabilistic diagnosis for COPD by using machine learning on sleep study data. And so when we made this platform, we had 3 goals in mind, and those were to achieve a medically viable accuracy, to create a platform that researchers could use to do further research using this sleep study data, and to produce a platform that would be able to be used by clinicians. And so we achieved a 75% precision in recall. We created a modular code base that allows plug-and-play classifiers for researchers, and we also integrated our platform with the clinician's workflow such that they could visualize data and generate reports in a similar way than they do now.
Thanks, Mike. So I'm going to talk about our solution architecture in particular. So the front end, a doctor or researcher can upload the sleep study data and then receive as output the patient's probabilistic diagnosis as well as the probability with which we are giving the diagnosis. Further, the doctor can view the sleep study data through a native visualizer, and relevant parts of the data are automatically tagged. And finally, a report can be generated. Now, in order to do any of this, to be able to provide the output, we need to first process the signals and the data themselves, and then feed these signals into our machine learning classifier. Well, I want to emphasize that, again, we took a modular approach such that future researchers will be able to plug in their own classifiers without having to worry about the boilerplate setup and saving them that work. I'm going to talk about our signal processing and machine learning solutions in particular. So behind me, you can see the data that clinicians showed us when they were talking about how you can tell if a patient has COPD. The top line for both patients is their airwaves, if they're breathing at night, and the bottom line is their blood oxygen. While we all stop breathing briefly overnight, you can see that with healthy patients on the bottom, their blood oxygen only drops a little bit and recovers quickly. Whereas for patients with COPD, their blood oxygen drops further, faster, and takes longer to recover. Therefore, our goal in our signal processing was to capture and quantize these sorts of data. So the technicals of our signal processing begin with cleaning out bad data. Unfortunately, we're in the world of biology, and what that means is you have technical instrument error. As you can see behind me, the patient's blood oxygen drops to 0. That, of course, didn't happen because otherwise they'd be dead. Fortunately, they weren't, and we can clean their data otherwise. Once we have this clean data, we attempt to discretize it. So we look at the number of times you stop breathing overnight, how low your blood oxygen drops, how long it takes you to recover. And we also use other demographic data that doctors also told us they use to predict patients. We then take all this discretized data and feed it into our machine learning classifier, which Sam will talk about now.
Thanks, Zane. So once we'd processed the signals, as Zane outlined, our challenge became how do we identify values of these signals or interactions between them that were representative of a patient with COPD. So to do so, on the machine learning side, we used a support vector machine, which provides a linear classification and a probability of classification. Additionally, we used AutoBoost, which is a method of aggregating the outputs of weak classifiers on different distributions to produce a single, stronger classifier. And so our machine learning solution outputs a probability of classification and a classification. So how well did we do? So the headline result is that we achieved 75% precision and 75% recall. So for those who don't know, precision is a measure of how many of those we diagnosed actually had the condition, and recall is a measure of how many of those affected by the condition did we correctly diagnose. So those results are if we classify every patient in the data set, but if we reduce our scope to only those patients who we are most certain about, we can achieve 90% precision and 30% recall, which is approaching medical usability standards. So that's how the back end worked. And sorry, I just want to emphasize that we made our platform such that future machine learning researchers can improve upon our results. So let's turn to how the front end works. So this is a demo of how a clinician would interact with our platform. So on the left, you can see a clinician can upload an EDF file containing all the sleep study data for a patient. The platform will then classify the data and provide a probability, and you can see on the right that it outputs the probability and provides a visualization of the EDF file. So the clinician can then scroll through the file, and the platform will automatically highlight points of interest. Finally, the platform produces a report which summarizes the result of our classification. So that's the solution. So who does the solution benefit? So first and foremost, the solution benefits patients who can have better and more accurate diagnoses and thus reduce the cost of care and achieve better outcomes. Likewise, doctors can better diagnose their patients and achieve better outcomes. Third, hospitals can reduce their malpractice costs. There's an interesting case study at Penn that a couple of years ago, a patient actually died because they weren't properly diagnosed with sleep apnea during a procedure. And so hospitals might be able to use our solution to better diagnose inpatients. Fourth, software providers of software that interacts with EDF files today could differentiate themselves from one another by offering our solution as a plug-in potentially. And last but not least, insurance companies could better stratify the risk of their patients and reduce per member per month costs, both of which impact their bottom line. I'll now hand it off to Kanishka.
Thanks, Sam. So let's take a look at who we're actually going to be helping and how many of them we can right now. So if you take a look at the 12 million Americans that are expected to be undiagnosed with COPD, this is a base rate of 3.7% of the American population. And this is an underestimate of the number of people with COPD from the people getting sleep studies due to the likelihood of comorbidities and what we saw within the data sets we looked at. So when you lump that in with the 3.5 million people getting sleep studies every year, as well as our 75% precision and recall, we see that in year one we have the potential to diagnose almost 100,000 new patients. And why this may not seem that high compared to the third largest cause of death in America, when you consider that $3,700 on average are saved per year per patient diagnosed early, this amounts to over $350 million in savings in year one. And these savings are lifelong for these patients, but in year one we see an amazing return. Now looking at our costs as a platform, we're a software solution, so they're actually not going to be that high. But if we look at it as a SaaS platform where we host it on something like AWS, if we look at the costs that are posted there, some sample costs from AWS, lumped all together when the average time we expect to run one of these sleep studies and a conservative estimate of that, we come out to $12 million a year in costs, leaving gross savings well over $300 million in year one. Now the only thing between us and getting to these patients is FDA approval. Fortunately for us, the FDA recently passed a Digital Health Innovation Action Plan, in which for low-risk technical solutions in the medical space, they're actually relaxing the constraints on what's required to get FDA approval. Specifically, SleepDX is a low-risk platform because we don't do anything to the patient to get these diagnoses that's medically harmful, and all we recommend at the end is that they go in for a spirometry test, which just involves blowing into a tube. Since both of these are low risk, we are on the right track to be fast-tracked for this FDA approval. So looking at extensions for our platform, COPD, in this specific COPD condition, our clinical advisor, Dr. Gunaratne, sits on the IRB board for Penn and actually plans to integrate with this with the 5,000 sleep studies done per year at Penn. If we can demonstrate the clinical viability through this, we can then pursue fast-tracked FDA approval and then go straight to consumers through both the sleep clinics that provide these sleep studies as well as the software providers that they use to view the data. Now, if we take a step back and look at our platform on the whole, we actually allow right now for ML researchers, as ML research continues to advance every day, to plug in a better classifier and experiment with those and get their results on testing these new methods. Additionally, for sleep researchers and medical researchers, they have the opportunity to test other non-sleep related conditions and just plug into our system. And there are a lot of other ones that the rich data has the potential to diagnose, including depression and asthma. Finally, anything we do in the medical space with data-driven technology improves customer and patient mentality towards this, and that's always an exciting thing in this evolving space. So in conclusion, we set out with the initial goals of having a medically viable accuracy of our product, a research platform that can be built upon, as well as a clinically integratable workflow. We achieved this with 75% precision and recall, already having ML and medical teams reaching out with research ideas, and great initial reaction from clinicians. We're really excited about this and the potential to save lives with our platform. We want to thank you all for your time, as well as our clinical and faculty advisor, and now we're open to any questions.
Yeah, so we started off with just the SVM, and then I think the AdaBoost was an attempt to build upon that. If you want to talk about that, Sam.
But yeah, so our advisor is Professor James Weimer, who's actually an ML researcher here. So he's sort of interested in like how to improve the SVM. And so we've made the product such that it can easily integrate with the research that he's doing. So yeah, just to emphasize, the platform is such that future machine learning researchers with maybe more experience than us can improve on our results as well.
To answer your question, we did try to improve it. Right. 75/75 is the best we could do.
Yeah, so there isn't necessarily a cure for COPD. Chronic obstructive pulmonary disease. So it's a bunch of conditions associated with the lung. It was formerly, like people referred to it as emphysema, and I think it's expanded from that to include a bunch of other pulmonary disease associated with your inability to breathe. So, sorry, would you mind recapping?
Yeah, so how many types of errors? Would you incorrectly said somebody had the condition? And also, why would somebody want to take this test if there's nothing they can do about it? Great, saves the insurance company money, too bad, right?
Yeah, so it depends, our type 2 errors depend on how many people we guess on. If we have to guess on everyone, then 25%, 1 minus 75 is the type 2 error. If we guess on only those we're certain about, it's 10%, 1 minus the 90%. We think while those sound a little bit high, the result is taking a spirometry test, which is a very short, painless procedure. So we weren't that concerned about the type 2 errors. And then saving money. So a lot of that money comes down to hospital visits. And so yes, that saves the insurance company money, but also when you know you have COPD, you are more ready and less apt to engage in dangerous behaviors. And the patient certainly wants to save hospital visits because every subsequent hospital visit they have, they come back sicker and less able to fight the next infection or what have you.
2 quick builds on that. We actually sent some of the ones we did have type 2 error on back to the clinicians at the sleep center because it's so rampantly undiagnosed that our test set might have had situations, and they've taken a look at those, and some of them they said they need to look a little further, but there's potential that they actually did have COPD. Additionally, with regards to what you can do, acute exacerbations of COPD is what's actually really dangerous. Sam alluded to that orthopedic surgery at Penn, where not knowing that actually cost the patient in that. And there's also a lot of, it's not necessarily a cure, but how the patient goes about monitoring this avoids those exacerbations.
And can you apply this kind of machine learning? Can you apply this kind of machine learning to other conditions?
Yeah, we might look at, so we showed you the airflow as well as the blood oxygen, which is obviously relevant to COPD. For something like depression, we would use the brain waves, which are also collected. So that's the advantage of sleep study data, is it's basically every biomarker you can imagine.
Yes, I know, but
sleep apnea in conductors who are very tired. Been surprised, so that has implications for morbidity and cost.
Yeah.
Thanks.
Thank you very much.
Thanks.
Thank you.